Hi everyone, it's Wednesday, time for Wisdom Wednesday. As you know, last week we began to look at statin use and the things that can happen with long-term statin use in terms of what it can do to increase risk for diabetes and abnormal metabolic function within the body. We know it can increase that risk, and we also know that if you really lower LDL, we know in people who've never really been on statins who have very low LDL, they have increased morbidity and mortality. So we really don't want to wipe LDL off the planet. But what we do need to do is understand that just a regular lipid panel that we get every year is generally not enough information to make really great clinical decisions when things are not all in the normal range. And even then, there are some issues. So I thought this week I would take a little bit deeper dive just as an introduction, and I'll continue this as we go on in the next several weeks to give you some more information about it. But I thought we would look at a particle called ApoB that is on the LDL, or what we call low density lipoprotein. And this is a protein that encircles the LDL. It's also on VLDL, which is very low density lipoprotein. And we are now discovering and realizing that it is this ApoB, or apolipoprotein B, that is on LDL particles, that is on the LDL itself. That particle is one of the major risk factors for what happens inside the arterial wall in the progression and formation and foundational beginning of plaque that occurs that can then become problematic and contribute to cardiovascular disease. It appears that it's these proteins, these apolipoprotein B particles, that can insert inside the wall. And it's not also that it's not only that they're in the wall, it's that how long they're in the wall in terms of what it does to initiate and progress the formation of plaque. It appears that LDL also comes in different sizes. There's small dense LDL and there's large fluffy LDL, and it's these small dense ones where the apolipoprotein B is invading the arterial wall, and these smaller ones can then increase the reactions within the wall that cause calcification and plaque formation through certain white cells called monocytes that then become macrophages and produce this plaque. So, knowing this, we look at things and from a scientific standpoint, okay, this is what does it. Now, how can we reduce it? And we do know that statins can lower apolipoprotein B, and it can show some regression in plaque. However, we're not seeing overwhelming reduction in cardiovascular disease. So why is that? Well, we know initially we do see some reduction in plaque formation. We see reduction in these foam cells and these macrophages, and they go down, and so we see some regression. However, the problem long-term is that when you are on these medications for years and years and years, now we see an increased risk for diabetes because we're not seeing lifestyle changes. We just see changes in labs. But from a lifestyle standpoint, your liver is still having to process all the carbohydrates that come in, all the processed foods. And unfortunately, we still see so much on the internet that says low-fat diet. And with rare exception, it's really not a low-fat diet that makes the difference here. It's understanding that we're overfueling the liver with too much in terms of perhaps mostly the most common micronutrient, which is carbohydrates. So it's not just a fat issue. It is truly more of a carbohydrate issue because that's what the liver does with excessive fuel that comes in. Now, that is the LDL side of it. And we all have heard about LDL being the bad cholesterol and HDL being the good cholesterol. And it is true that HDL, for the most part, with the large fluffy HDL particles, these tend to be the sweepers. They come in and sweep up all this damage and help clear out plaque and take all of this damaged material back into the liver for reprocessing and getting back out into the system in a healthier way. So what we want to do is reduce LDL and raise HDL. We have no drugs that raise HDL. All of the studies and all of the research being done has never really shown any way to increase HDL. And on the HDL particle, there is an apolipoprotein, and that is apolipoprotein A. So we have apolipoprotein A and apolipoprotein B. B being bad, let's say, and A being advantageous. So ultimately what we want to see is increasing in HDL, lowering of LDL, in addition to triglycerides. For those of you who come to see me, you know that when we look at a lipid panel, we are looking at the triglyceride to HDL ratio, and we'd like it at least less than 2-to-1, but optimal seems to be around 1-to-1. So you want that triglyceride and HDL level to be close to each other, if not have your triglycerides less than the HDL level. This is a really good thing for your overall health and wellness and for your arterial benefit so that plaque does not form. But what improves HDL? Well, I'll tell you, there's only two things that can raise HDL, and that is exercise and that is estrogen. And that's estrogen for both men and women. So as we move forward in the next several weeks, I'm going to dive a little bit deeper into those things so that you understand how these things work and how our hormones work. And for those of you men out there who are on testosterone and you are encouraged to take an aromatase inhibitor to prevent your testosterone from being aromatized into estrogen, I would suggest that perhaps we might want to relook at that, because it's that estrogen that actually, even in the male body, is very advantageous from a cardiovascular standpoint. And certainly for women, we know that women tend to have less heart disease. It doesn't mean that we don't have it, but we do tend to have less heart disease, at least earlier in our life, while we are still making a lot of estrogen. And for women who are on a hormone program, we know that your risk is lower with the estrogen. If you have not done, for instance, a cardiac calcium score, that also is a great way to get a good baseline without having to have anything invasively done. And it's a very simple test. It's called a cardiac calcium score or coronary artery calcium score. It's an easy test to be run. It's a quick little rapid CT scan that is great information and allows us to look at calcium deposition in the arterial vessels of the heart. And even though many are told you can't do anything about it, and often that's true, but there are things that we see, ways with hormonal evaluation and hormonal replacement, as well as exercise. Exercise can induce what we call collateral flow in the heart, and the HDL, the rise in HDL, can actually help clear plaque, and we can actually see that happen. But there's no drugs that really do that ultimately, other than this ability of the hormones to do the work. So I just wanted to share this information about the particles that are really the most important information to know. It's nice to have a lipid panel, but it really doesn't tell us everything we need to know, and in and of itself is not as important as getting more in-depth reading if you have abnormal values on your lipid panel. So just a little brief introduction. Hope that's something that makes sense to you, and we'll continue to look at this, particularly from the standpoint of diet, nutrition, as well as insulin resistance. It all comes around. We've been talking about this an awful lot in the last year and a half, about reducing triglycerides and raising HDL and reducing our risk for diabetes by lowering insulin resistance and becoming more sensitive, and looking at diet and nutrition and lifestyle issues. So it all is part of the same process. And this happens in the heart, it happens in the brain, it happens in all our organs. But the heart, of course, is seemingly the most common one that is affected initially in terms of life-threatening. So, but it can affect all organs, having plaque within your vasculature. So we will work together to continue to look at ways to improve our health, and certainly a hormone program is one of the best ways to do that from our perspective. Hope you all have a great week, and we'll talk again next week.